Do you hear me? Is it okay to continue?
Yeah, we hear you. You can continue. Sorry.
No, that's fine. Yeah, I was talking about the intersectional approach and to see what that means in itself. It tells that we cannot look at that factor independently. We should see that they are interconnected, they are interacting with each other. And then another examples that I was giving, that it was when we are looking at the women or men group, they are not a homogen group, it's a heterogen, because women, they can be like different educational background, different family background, socio-economical background, and other factors that play a role in differentiating different women. I have used an intersectional analysis concerning COVID-19 pandemic and how it could have improved our understanding of the pandemic, how to approach that and how to manage it. Reviewing the intensive wave of blaming different minority, including ethnic and religious group during the initial phase of pandemic, as I have referred in the beginning of my presentation, emphasized the critical need to have a holistic intersectional approach. Many in different countries witness careless expression of not only the lay people or politicians, but also the healthcare professionals in attributing the speedy spread of infection or specific social groups, social categories including ethnicity, social class, gender, and such are interconnected and interacting in creating disadvantages for the individual and health equalities in the society. One of the factors that I have looked at is ethnicity. This is a concrete example that when during the COVID, they have attributed a spread of disease to some immigrant groups, since the statistics in different countries indicated that there is higher prevalence and mortality among immigrant and ethnic groups. But when we are looking a bit closer, we see that many of these immigrant groups, for example, in Sweden, they were living in much smaller accommodation. So it means that when you are living in a small house, it means that there is more people in the same room. So there is more contact and then more probability to get sick. They also live in crowded area. It's not just only their flat or their home that are living, also the area that are living is condensed and is crowded. So many of these blamed immigrants work in low-pay sectors that needed physical presence, and they were not having the possibility to work from home. For example, they have been working in transport, they have been driver, bus driver, taxi driver, or they were working in the maintenance or in the care, lots of healthcare aides or like the cleaner or other service jobs. They were working in that. So these jobs means that you should be present at your workplace, and lots of these people traveling by the public transport to the workplace. All of these things means more exposure to the infection and getting sick. And also there's other factors if you are looking just the factor ethnicity and race. There is different lifestyle, health literacy has been lower, it's education, poor housing, income is and also lots of them have had pre-existing health condition, and they have not the same extended of social networks as the other groups compared to the people that newly arrived or have been shorter time in that country. Another aspect is also numerous studies shows that the lower level of vitamin D are associated to severity of the disease among the patients. So people with a darker skin, some of the immigrants group, had higher risk of absorbing less vitamin D, especially in the countries with less sunny day. So that shows that this phenomenon is multi-layered and complex and cannot be simply understood. Or the statistic shows that the COVID is higher among, for example, one special immigrant group or all immigrant groups, and then can concluding that, oh, there is some problem. They are missing something, or they should do something themselves. Perhaps the structure and the society should take some measure. It is also important to note that historical mistrust of some marginal and minority groups to the healthcare system and power structure might decrease their willingness to seek help if they need help, and not come to be detected and get helped. Another aspect is that gender and also sex, because we can look at that from two different aspects. If it's from the biological aspect, then it will be discussion about the sex. And if it's from the social aspect, is the discussion about the gender. The literature described the disproportional impact of pandemic on women and men, but it fails to see each of the women and men as heterogeneous group. It also needs to differentiate between the concept of gender as a social construction and as sex as a biological. Many studies, especially in the earlier phase of pandemic, reported higher mortality among men compared to women, but later studies showed the mortality is higher among older men and more equal in younger age. So it's not only the gender is important, the age is important, because age, it was, according to some of the studies, it was no differences between younger men and younger women, but in older age, it was different. But if we look at the biological aspect, it was some differences between these two groups in terms of immune response to COVID-19 infection. So some study has noted, some study also has noted differences in efficacy of vaccine among the sexes. Both sex-specific chromosomes and also the hormones, in particular testosterone, estrogen, and progesterone, were found to play a substantial role on COVID, on coronavirus binding to cell receptors and also the converting enzymes of ACE2. Stronger immune responses have been reported in women, including higher level of immunoglobulin and antibody responses. The main body of literature in the field describes the direct and immediate reaction of the women and men's body to the infection or the gender-related outcomes. But how we can discuss it from the intersectional perspective, we need extra effort to see how gender intersects with other social determination of the health, both the primary impact and the secondary impact. The secondary impact hit the women harder because it's the women that are usually and traditionally take care of sick people in the family as informal caregivers, and also their networks, not only the family. This socially norm behavior put them at greater risk of getting infected. Moreover, lots of women work in the healthcare system. So all the postponed care and treatment, surgery, it will be them that are taking care of such patient later and then get infected, affected again. As conclusion, I would say that COVID-19 pandemic revealed fragility in healthcare system and vulnerability regarding to health equalities in the society. The healthcare policymakers, politicians, and healthcare workers need to be equipped with an understanding on how the intersecting patterns of health equality among people with diverse backgrounds in society, factors which might not to be visible to them, and the way they interact with health and disease, including factors such as ethnicity, social class, gender, education, religion, economy, size of family, among other factors. The intersectional approach helps to recognize the real problem, not the surface, and the roots of that, Therefore, they can prepare the ground of setting policies and planning strategies to decrease the health disparities. Addressing the structural and systematic races within healthcare is substantial in attempting to reduce health inequalities in the society. Without such structural changes, the health inequalities and vulnerability could not be diminished in society, the conditions which intensifies during the pandemic. And I have some few recommendations based on this study, because the literature calls for implementing the intersectional approach when conducting research on people and about the health, though the research studies using unidimensional approach are dominant in literature, which study just a single dimension at a time and do not consider the interplay of social categories. Such studies have been shown too simplistic and misleading, even though easier to conduct. Health inequalities have deteriorated COVID-19 related vulnerabilities. Any intervention to promote the health for everyone and decrease the health disparities should consider the interaction of different power structures and social categories in each context. The structural and systematic races within healthcare should be studied, recognized, and considered in tailoring the intervention. An intersectional approach helps to display the interaction of different power structure and social categories which put people at different risk of infection or mortality of COVID-19. And in this presentation, I took two factors, gender and ethnicity, but I have presented other social factors in this chapter that you can read in upcoming book. An intersectional approach should be used not only to understand the pandemic impact on people, but also when planning the healthcare policies, care plans, and support services. And here is again the name of the book if you want. So no, I'm looking forward to your questions or comments, any correction and discussion point.
Okay, thank you very much, Professor Monir, for your nice presentation. And this time for the question and comment. For the audience, do you have any question?
I just want to share our experience from Thailand, because we have also a similar problem. We have workers who come from the country nearby, and then the place that they live at the workplace is very small and tight. That make the public health prevention of the COVID-19 is very hard to do and to control. So what the Ministry of Public Health do is they have like a system for the employer to improve the living at the each factory, something like that, and it's help for the people to control themselves. It's like a factory quarantine or factory control, something like that. Thank you.
Thank you so much.
Thank you very much for your nice question and comment. We still have the few minutes. Do you have any question? Okay. If no